Okay, so picking up with anesthetic equipment is basically any parts. So, I always focus on the anesthetic machine, but what are all the parts and all the pieces of equipment that we use to deliver anesthesia or to help in delivery? And primarily, we're speaking of delivering inhalant agents. And one of the first things we talk about is the endotracheal tubes. And these are basically a flexible plastic tube. And, the reason you give induction agents is to facilitate intubation. So the induction agents bring you to stage 3, plane 1, where they will open their mouth, you can pull out the tongue, and you can pass a tube into the trachea. And the goal of doing this is you want to get anesthetic gas closest to the lungs. Now, let me talk about something here called dead space. And you have to understand what dead space is. Dead space is any area within the breathing system or the animal where there is non-functional gas exchange. Gas exchange occurs in the alveoli, and gas exchange is when the oxygen and inhalant that they inhale move from the alveoli to the capillary. And that is the goal. The animal has to inhale the oxygen and anesthetic and get it to diffuse in the blood. So if you think about it, you have to conceptualize for a minute. When you have an animal that is intubated and they're going to be hooked up to a breathing system that's hooked up to a machine, the machine in all of its parts and all of the tubing and the animal are all connected, okay? The animal has to get the anesthetic coming from the machine all the way to the deep parts of the alveoli to exchange. So when oxygen comes through the vaporizer, goes through all of the tubing, it has to get into the patient. All of those areas from the machine to the patient are considered dead space because there's no exchange. When you intubate an animal, when we intubate them, it goes right, the tube is supposed to sit at the bifurcation. Do you remember in anatomy, the trachea comes down and it splits to both sides of the lungs? And that split in the trachea is called the bifurcation. When you put a tube in an animal, the tip of the tube is supposed to sit at that bifurcation. If you push it too far, it would go one side or the other. So you want it to go right to, so it delivers equal oxygen anesthetic to both sides of the lungs. By doing intubation, you minimize what's called anatomical dead space. Let me back up. You could sometimes anesthetize an animal with a mask, where you put a mask on their face and they inhale through the mask. But then the anesthetic gas has to travel through the nares, through the nasal passages, through the pharynx, through the trachea, all the way down to the bronchioles, to the alveoli. If you intubate, I bypass nares, nasal passages, pharynx, larynx, and you bring it all the way to the bifurcation of the trachea. So do you see how I've taken away all those areas of dead space and I'm bringing the anesthetic closer? So, and this is a perfect test question, is like, what is one of the goals, or why do we intubate? I mean, why intubate? What is the time difference? What do you mean by that?
Yeah, that was kind of worded bad. Sorry.
That's okay.
I like with the ET2, I assume since it's like bypassing all of that, it would be a lot faster, no?
Yes. So essentially, it's more efficient. Yes. So you have more efficient delivery, and because you're getting closer. Speed wise, the only difference, and let me explain, is in order to get a tube in, you have to give an induction agent. Normally, you don't usually give an induction agent and put them on a mask. If you use a mask, usually that's your induction. So that's why it takes longer. And so the goal of like an induction is to put a tube in. In theory, say you had an animal you couldn't intubate, say they had trauma or an injury, You could give them propofol and put a mask on to just keep them asleep. And yes, but it is faster because again, you are bypassing. So I would say the better way to say it is it's more efficient delivery.
Yeah, so it's not necessarily like about time.
Right, but it is you're making it easier on the patient because if you think about when they inhale, if they're inhaling from a mask, they have to pull that gas all the way through all those structures. If you intubate, they're only pulling it from here, so you're bringing it a lot closer. And sometimes people don't understand what I mean by bypass because the tube is going through those structures, but the gas is traveling through that tube. It's not traveling through those structures.
No, yeah, I get that. Like it's not
Okay,
gonna get absorbed in the tissues there.
exactly. It's not getting diluted out. It's not traveling through those tissues. So as long as you understand what dead space means, and that's just, like I said, nothing's happening in the nares, the pharynx, or the trachea. The gas is just moving through. It has to get to the alveoli to cause an effect, to diffuse. And so if you can be more efficient and get it closer to the area where it's actually going to diffuse, then it's better for the patient, more efficient. They're not having to, so it's essentially easier for them to inhale it or breathe it in. The other advantage, because, this is like a perfect essay question. It's like, why do you intubate patients? What are the advantages? Well, this is everything, it delivers it from the machine to the lungs, and also you maintain an open airway. The problem is when you put a mask on a patient, and especially if you had like a bulldog or another brachycephalic, the problem is they can have airway compromise, and it may be that airways can collapse, and sometimes you may have to emergency intubate if the patient's not doing well. If you already have an airway in, and when I say you have an airway, it means you have a tube in the trachea. Then you have an open airway in case there's a problem. So you already have the airway, you have precise administration. But the other thing is it prevents pulmonary aspiration. I'm going to show you pictures of these tubes. On the end of the tube, there's like a balloon. It's called a cuff. Now, think about it this way. If this is the trachea and this is the tube, okay, there's space, because very rarely are you going to put a tube in an animal that's perfectly fitted to their size trachea. You always want to put in the biggest tube you can for your patient. But what you're going to do is you're going to blow up that little balloon, and it's going to take up the whole space. So what happens if you have a tube in and the cuff is blown up, if they go to vomit, it's going to prevent that vomitus or aspiration from going into the lungs. So first of all, it prevents aspiration pneumonia. If they have passive regurgitation, remember I told you sometimes animals will be laying on the table and you'll notice they're starting to pool liquid in their mouth, or sometimes you'll see some dripping out of their nose, and that's passive stomach contents just kind of creeping up the esophagus and coming out. But sometimes some of that can go back into the trachea. If you're intubated with a blown cuff, then that regurgitated fluid isn't going to make it down the trachea. So you have a protected airway, a maintained airway. You can respond to a respiratory emergency. One thing, if I have not made clear, if you have a mask on a patient's nose, you cannot bag them. If you squeeze the bag, you're just going to blow up their cheeks. Believe it or not, oxygen and anesthetic just don't push their way down. I mean, you might get, it really doesn't work. If you needed to bag a patient because they stopped breathing, they were apneic, or say they weren't breathing enough, they were severely respiratory depressed, they need to have a tube in the trachea so you can deliver ventilation. So if you have a respiratory emergency, I'd much rather have an endotracheal tube in the trachea. And you can monitor respirations. The tubes that we have in surgery, they are clear. And when an animal exhales, every time they exhale, the tube fogs. If you see fogging. So there's lots of ways to monitor breathing when they're anesthetized, but that's one way is you can look at the fogging. And especially sometimes with like cats, you know, they don't breathe very deep and they don't sometimes move their bag or their chest very much. And sometimes it's difficult when, you know, if you've seen in surgery, they got these big drapes laying over them and you don't always see them breathing. You can watch the tube and watch the fogging. So these are all advantages to why do you intubate a patient. And, you know, you should be able to, you should be able to kind of identify that. There's two types of endotracheal tubes. The main one that we use every day in surgery is called a Murphy tube, and the end is beveled. So if you know what a beveled edge, you know, from a needle, it has kind of that angled edge. It's not flat cut, it's a bevel. And the bevel, the tip helps you get in between the larynx. You can take the tip and kind of, you know, when you go to intubate, sometimes the animal's larynx is just open. You pull down the epiglottis and the larynx is open, and you can just, sometimes, like especially in cats, they're kind of like open, close, and you have to kind of time it of when you're gonna, but if you take that tip of the bevel, you can get in between the larynx and get the tube in. So that's the beveled edge. And they usually have a cuff. And the thing about the Murphy tube is they have what's called a Murphy eye or a side hole. There is a hole on the side of the tube. And I'll show you on the picture. A cold tube doesn't have a side hole and it doesn't typically have a cuff. You can get them with a cuff, but the benefit is, and what happens is the tube at the end decreases in diameter. The tip becomes more narrow, but that's more in exotics like birds or reptiles. And sometimes they don't want the cuff. They don't want to cause damage to the trachea. So here's the different kinds of tubes. I'm going to come back to that for a second, but this is a basic Murphy tube right here, okay? And you can see letter H right here. That's the balloon, that's the cuff that you fill. This syringe attaches here. This is called a quick release valve. You have to push it in and give it like a half twist, and then you can put air in it. This is one thing. I will have tubes. That last day we meet in week 8, I'll have tubes in here and I'll have syringes. You guys can practice filling these cuffs. So you can get the practice of, because there's a special way to do it that I just explained. Here's the tip of the tube, and letter J is the Murphy eye. If for some reason the end of this tube got obstructed with like mucus or something, the animal could get air, oxygen, and anesthetic through that hole. So the side eye or the Murphy eye is just another opening to access air if the end gets plugged for some reason. A lot of times, a lot of clinics will have hooks, like command hooks on the wall, and they will hang the tubes via that hole. I mean, that's fine. There's no problem in doing that. But I had a student, she's like, the hole is so you can hang it on the wall. No, the hole is for another area for them to get oxygen anesthetic. You know, yes, you can hang it. Some clinics keep them in a drawer. They should be protected from like dust and the air. So, you know, I don't like when they're just open to the air on a rack, but a lot of clinics keep their tubes out there. Now, let me explain. Letter I down here, this is the part of the tube that goes into the patient. So the beveled edge with the Murphy eye is what goes into the trachea. The opposite end, C, letter C, that is what hooks up to the breathing system, the rebreathing tubing. And letter C is a universal connector, meaning it doesn't matter if this is a cat tube or a German Shepherd tube. The diameter of that opening is the same because it hooks up. The breathing system connectors are universal. So you can hook up a breathing system to a variety of sizes of tubes. that's basically what I'm, so that's that letter D and letter C. This is what hooks up. You've got the endotracheal, the machine end, and D is the connector. That's what hooks up. Letter E is this kind of string right here. When you put it in the patient, you're going to have to secure it to their jaw. So you usually, some people, this is actually, some clinics do this. This is IV tubing. So when an animal's done with surgery, you can disconnect the IV line, throw away the fluid bag, and you can cut the IV line in pieces. And some people use that as a tie. We used, we had roll gauze, which was like thin gauze, and that's usually what I used. Is I would tie, when I put my tube in, I would tie it around the tube, and then I tie it to the top jaw. Cats, I usually tie it behind their ears, but on dogs, as long as they had a decent snout, like sometimes if it was a Frenchie, I would tie behind the ears because they had like, or if it's a, you know, a Boston or whatever. I mean, sometimes you do have to go behind the ears, but most of the time I like to tie it on top of the nose, and I like to tie it behind the canines. So if the tube was begin to slip, sometimes the canines will catch, because it's happened in surgery where all of a sudden the patient's waking up. This happened at Purdue, and I turn and the girl's like, he's waking up. And I look down and I'm like, your endotracheal tube is on the ground. So she hadn't noticed that it had started to slip out. It wasn't tied in very well, and the whole tube came out of the animal. So we had to give him propofol and intubate him on the table, you know, and it can happen if you don't secure your tube well enough. So that's what that is right there. But let me go back to the types of tubes. Whoops. So letter A is, now letters A, C, D, and E are all types of Murphy tubes, but they're made with different materials. This top, and the next slide talks about the materials, but letter A is a silicone tube, and silicone, same thing that they make like implants out of, or medical implants. Silicone is very non-irritating to the tissues, except they're expensive. Silicone is very, it's bendable, it's pliable, it's like atraumatic because it's a softer plastic. But again, it can get bit sometimes when they're extubating, and they can bite through it because it is kind of soft. But it is the best for the airway. It causes least reactions. And it is somewhat clear. It does have a little bit of a color to it. Letter B, do you see, this is your cold tube. So letter B, and the cold tubes are typically a solid color, so you can't see through and see that fogging. And do you see how the end, it gets narrower? So it has a change in diameter at the tip, which helps with birds and reptiles. It helps to have a more rigid tube with that narrow tip. So that's why they like to use these in, you know, I refer all that to Nemer, but that's what they're typically used for. Letter C is probably what most of you guys will have at clinics. This is a polyvinyl chloride, and it's clear. So this is the one that you can, when they breathe, they will fog. The nice thing is too, sometimes I've had patients, sometimes I've seen blood come up, sometimes I've seen mucus. So like if they have a discharge, if they cough on extubation, you can look at it and say, wow, look there, you know, there's some mucus here, there's potentially blood. You can see all that. And I like the clear tubes. They are more rigid. You can still use them in the airway, and you still have to be careful. And a lot of these are human-based tubes. Humans have a natural curve to their trachea, so most of these tubes do come curved. Letter D is probably my least favorite, and this is the red rubber. Well, even though it's orange, they're called red rubber ET tubes, but they are not see-through. Now, they are the softest, but they are more prone to kink or collapse. Like, I don't know how many times, and take this to heart, how many times I've seen people doing a dental, and sometimes they're bending the head in different directions to try and get to the back teeth. And then all of a sudden, like the tube is bent in half. And then all of a sudden the patient is having a hard time breathing because the tube is collapsed. So whenever you have a patient in a surgery in a very odd position, you have to pay attention to the ET tube, because sometimes the silicone, they do resist collapse, but they are softer. These definitely can collapse or kink, so you have to watch them close. Also, this does absorb the plastic, so it does, you know, it can absorb, like, one thing, and I know some of you are working in places now, and part of my advice is, normally in surgery, you have a tub, and sometimes people put like a Novosan, you know, that blue chlorhexidine cleanser. And then sometimes throughout the day, when they're done with surgery, they just throw their endotracheal tubes in this tub of cleanser, and it sits all day. Well, that plastic can sit and absorb that chemical. And then you don't clean them till you go to leave at 5, 6 o'clock. And then you clean these tubes, and they've been sitting in this cleanser, especially if you're using these red rubbers. That plastic can absorb. And then the problem is, you go to put that tube in another patient, and it can cause a tracheitis, because then their airway humidifies and warms the tube, and it causes leakage of that chemical. And they did a study and traced these cats were having a lot of coughing after surgery, and coughing was turning into more than just the couple day cough, and they were having a tracheitis, and these tubes had this chemical because they were soaking their tubes. I used to keep a tub of water. When I did radiation, I had a tub of water in our sink, hot water. Of course, it turned cold, but I would put the tubes in there so they at least didn't get dry and gunky. And then the end of the day, I would dump the water, and then I'd fill it with hot water and cleanser and let them sit for 10 minutes while I cleaned and finished up my day, and then I would clean them. So I didn't have them soaking all day, but I had them in a tub of water, because a lot of them have like spit and saliva, and if it sits there and it dries, it's hard. It's kind of like putting a pan in the sink, like you've got something baked on. Put it in some water, let it soak, so then when you go to clean it, I mean, it's the same theory, is that I just don't like that they sit in cleanser like all day long. That's just something that you want to be cautious of. Let me mention something about post-op coughing and endotracheal tubes. And this is I always try to give you guys tips as far as client ed. When I would discharge patients, it's very common that they cough after surgery. And most people understand that, because a lot of owners have had surgery, and maybe they know, oh yeah, I coughed for a few days. But I say it's normal for, Bo to cough a couple days after surgery. It should get better after 2 to 3 days. But the keys here is, I would tell them, if it interferes with eating or sleeping, if they can't sleep through the night without coughing, if they can't finish a meal or drink a bowl of water without coughing, you need to let us know, because a post-op cough, it shouldn't get worse days 2 and 3, but it can progress to a potential pneumonia, or maybe there was some chemical. Sometimes they do need a cough suppressant. So you need to let clients know, what to expect. Again, a little bit of coughing, it shouldn't interfere with their daily activities, sleeping and eating being of importance. Now, here's some notes. I talked about the polyvinyl chloride, the red rubber, the silicone. There are standard lengths to these tubes. They come in different diameters, but they do usually come in standard lengths. But when we choose an endotracheal tube for our animal, we're going to choose it based on the ID. And let me just explain this real quick. Actually, there's not a good, let me go back, sorry. It's hard to see on this tube, and I will show you this when we have tubes in person, but in your book, this is why you guys got to look in your book for stuff, but what letter G is pointing to on here is the ID number. It would say like 8.0 ID. So if I tell you, hey, Bethany, go get me an 8 tube for this patient, I want you to look at it at the ID number. The problem is there is also what's called an OD number, which is the outer diameter. That is not the size of the tube. So when we size tubes for our patient, you go by the ID number. So if I say get a 7, a 7.5, an 8, a 12, you want to look for the ID. Now there's all these other little marks here. These are centimeter marks as far as length. That doesn't really pertain. When you guys put a tube in, we're going to stop at the thoracic inlet. Now you could measure it and say, oh, the end of their mouth is at the 30 centimeter mark. So sometimes I'll use that number as a guide on how far, because usually I measure my tube on the outside of my patient to get an idea of how far I'm going to put it in. Because again, these tubes are definitely cat tubes are too long for most cats. You don't want to bury the tube to the tip and then it'll go down one side of the lungs. So I'd rather have tubes sticking out of a patient, like too much tube, than too far in, okay? So, and I will talk about that tomorrow. That's where I will pick up on and kind of talk about the sizing a little bit. Do you have any questions thus far?
I can't think